Hello. Hello. Hello.
Sorry for the interruption. Carry on.
Yes. Uh, uh, with whom you are living?
I'm living with my boyfriend.
Okay. What do you do for your job?
I am a teacher.
Okay. Does your symptoms affecting your day-to-day life activity and your work in your workplace?
Yes, very badly.
Okay. I would like to involve a social health worker and occupational health officer to help you regarding in this matter.
Thank you. 2 minutes remaining.
Okay. So I want to ask you some private question. Tell me about your periods. Is that regular?
Yes.
Okay. Any change in volume?
No, the usual.
Okay. Do you have any history of miscarriage or delivery?
Never.
Okay. Are you on any pills? Any birth control pill?
Yes.
Okay. Do you have any time leg swelling? Any painful or painless leg swelling?
No.
Okay. So tell me, what is your concern?
What do I have?
Okay. After talking with you, I have some possibilities in my mind. But before I want to examine you first. Now I am telling that what is in my mind. That is I am thinking a condition. That is called. We call this uh, rheumatoid arthritis. That is called rheumatoid arthritis. Okay, that is a problem with your immune system, that is body defense mechanism. In that case, it can attack. It can attack your joints as well as before this. I have another possibility in my mind, that is called sarcoidosis. Okay. Sarcoidosis, maybe there is a possibility because you have got some sorts of sarcoidosis. This is a problem also. This is problem. So I like to involve a multidisciplinary team involving joint doctor and other doctors as well. And I want to run some blood tests and imaging, and would like to arrange another meeting to tell about the diagnosis, that is investigation results, and the management plan. For the time being, I will give you something painkiller. Oh, sorry. I think you have to admit now for some urgent blood test and some thing. I think I need to assist because
Thank you.
Okay. Do you have any other concern?
Nope. Thank you.
Okay.
Let's start the fighting parts. Okay. Every station is divided into 3 parts. First, we get the fighting going. Then we get the differentials and the pitfalls. And lastly, we apply that into a sensible approach for whatever this case it is about. Let's agree from the very beginning that the diagnosis is never an important issue. I never care about the diagnosis. I care about the approach to that diagnosis, because nobody knows what will you get in your exam. So let's enumerate the positive data. What are the positive data in your scenario?
Yes, a 30 years old lady comes with joint pain, and she gives history of painful skin rashes over her leg. That is most likely erythema nodosum, and also history of red eye. That may be uveitis, maybe uveitis, and there is symptoms of hypercalcemia like polyuria, polydipsia, heart motion. I think all of things in favor of sarcoidosis, though there is the lung symptoms that is are absent that I expected.
Okay, so the first question is, does she have any photosensitive rash?
Yes, she told me about a photosensitive rash.
Did you ask her about a rash on exposure to the sun?
Yes.
Which part of her body it involves?
Which part of the body is involved? I didn't ask about it.
Exactly, you didn't ask about it. Okay, so your number one differential is going to be
Sarcoidosis.
sarcoidosis. What else you may consider in this lady?
Actually, also can
I cannot hear you.
as systemic lupus erythematosus and rheumatoid arthritis can also be considered.
And rheumatoid arthritis can be also considered. Does she have HIV?
I didn't ask
Is
about
it possible for HIV to precipitate such symptoms?
joint pain in form of polyarthritis.
And she also has weight loss to add in here.
Okay.
And poor appetite. Okay, so HIV was not ruled out. TB, does she have TB?
Okay.
Okay, what is your differential diagnosis for hypercalcemia?
For hypercalcemia, as she hypercalcemia, here sarcoidosis, then hyperparathyroidism.
Hyperparathyroidism in a 30 years old lady. How can you explain that? Does she have cancer?
Like men 1, men 2, sarcoid and cancer,
Yes.
I think.
Thank you. So those are your top 4 differentials for hypercalcemia. Does this lady have any postural hypertension?
Postural hypertension. I didn't ask about the postural.
Okay. And is this lady in heart failure? Is she anemic or in heart failure?
Postural tension. Actually, I don't know.
You did not ask about that. So, what is the take-home message from this case? The take-home message, first of all, let's agree that you have done well overall. But the systemic review is one of the major problems that we need to fix before the exam. So systemic review needs a little bit more of an attention towards you or from you because you have missed some symptoms in the CNS, missed some symptoms in the cardiovascular, and missed some symptoms in the GIT as well. Travel history was not assessed at all, and the family history was not done in 3 questions as you should have. So what is the differential for this case? Let's agree first on the pitfall paper. There is one very important point. 1, any premenopausal female with unexplained rash, unexplained lymphadenopathy, unexplained cytopenia, meaning low white blood cell counts, hemoglobin, or platelet counts, the diagnosis is usually lupus till proven otherwise. Agree?
Yes, I think.
Agree. This is the first point. Second point, there is something called the family package. The family package are 4 diseases that come in the same offer. When you go to the supermarkets to get or to buy something and you find a family offer, you buy 4 products for the price of 1. Those 4 products, once you have one of them in the differential, the rest of your differential, and those are HIV, TB, cancer, and lymphoma. One by one, how do you rule out HIV?
By taking sexual history.
How many questions?
There, I think there's blood-borne disease 6 points. Then
6 points. Why 6 points? HIV is mainly transmitted through sex. This is sex. I hate memorizing anything, so I need to put them all in something like a mnemonic or something to remember it well. Those are, one, the intimate relationship, then any tattooing, piercing, needle sharing, surgery, and transfusion. So, Dr. Asma, how many factors do we have to rule out for HIV or any blood-borne virus, hepatitis E, C, Epstein-Barr, whatever? How many? 6 points. Then comes the point of TB. How do you rule out TB in any case?
TB by taking free history.
I cannot hear you properly.
Free history.
What are the points to rule out TB through?
As he has been in contact with any TB patient.
Okay, and what else?
And travel history.
Travel history. We did mention that before. If on the screen we have the ugly TV on the right side and the happy patient or Mr. Stewart on the left side, in order for the happy patient to get TB, either the patient will go to the TB or the TB will come to the patient. The patient will go to the TB, so there will be travel history. Or the TB will come to the patient through someone traveling from an endemic area and the patient is dealing with that traveler. So the patient can be working as a custom check officer or a border control check officer in the airports or a hotel receptionist or anyone who's dealing with tourists coming from endemic areas. So this is the patient's job. So we have two risk factors mainly for TB, and those are travel history and the patient's job in general. Agree?
Yes.
Agree. So HIV ruled out, TB ruled out. Cancer, how do you rule out cancer in any patient regardless of the age?
By two things, clinical pictures and family history.
Perfect. And the earliest clinical picture of cancer is going to be?
Weight loss and pallor.
Pallor, before even the weight loss. And pallor, anemia, iron deficiency anemia. What else as a clinical picture you can expect to have from the anemia? Come again?
Lumps and bumps.
I cannot hear you properly, Dr. Asma.
Lumps and bumps.
Okay, I'm talking about the clinical picture of anemia.
Okay. Pain, that is dizziness, fatigue.
Dizziness on standing from a seated position. And
Yes.
this is postural hypotension. Postural hypotension has been the diagnosis in one of the recent cases as well, not in Oman, but in this site as well. What is your differential diagnosis for postural hypotension?
Postural hypertension, it can be Addison's.
Okay, Addison or hypoadrenalism. How many points first before we discuss that? 4 points. One is Addison. Agree. What else?
Drug-induced hypertension.
Agree. Drug-induced. And what are the drugs that can induce postural hypotension?
Basically, vasodilators, drug, ACE inhibitor, amlodipine,
Okay.
alpha blocker.
Okay, let's make it simple. A, alpha, beta, delta.
Diuretics.
ACE inhibitors, alpha blockers, beta blockers, and diuretics. Those are the drugs that usually precipitate hypotension, autonomic neuropathy, and lastly, anemia. Those are your top differentials for postural hypotension. So how many differentials for postural hypotension?
4 differentials.
4 differentials. Other differentials do also exist, but those are the common ones in the basis exam. And what is the most feared complication of anemia?
That is heart failure.
And how do you rule out heart failure in any patient?
Paroxysmal nocturnal dyspnea and orthopnea.
Thank you. The nocturnal symptoms. By 2 questions. Do you wake up at night gasping for air? And did you increase the number of pillows that you have been recently using. Increase in the number of pillows, not the actual number. If he has been using 2 pillows and now still using 2 pillows, it makes no difference. If he has been using 5 pillows and still 5 pillows, no difference. But if he's using 1 pillow and now he's using 2, this is an increase. This is significant. Make sense?
Yes.
Okay, so those are regarding the clinical picture and how to rule out cancer in any patient. How many questions do we have for the family history?
Family history, 3 things.
3 questions, and those are any family history of a similar condition, any disease that runs in the family, and any family history of note, open-ended question, versus family history of cancer or sudden death. Not sudden cardiac, sudden death. So we put the family history in 3 questions because this is a common pitfall in the exam, not to give you the full history unless you ask all the questions in details. So whenever it comes to the family history, I want you please to be boring when you ask about the family history. Be very boring when you ask about it in order not to forget or to miss any points. This is cancer, and lymphoma will essentially follow the same sequence of the clinical picture of cancer. Moving on. What is your differential diagnosis for erythema nodosum?
For erythema nodosum, yes, nodosum.
I want you to give me 1,752 differentials. Can you do that?
No.
You can. Simply because the differential diagnosis of erythema nodosum is?
That's
Anything. It can be physiological, it can be post-infection, it can be endocrine, it can be whatever. So having erythema nodosum in your scenario, and this is the other pitfall here, does not have to mean anything. Whenever someone, for unknown reason, most of us, whenever they see erythema nodosum in the scenario, they will consider sarcoidosis or TB or something specific. Erythema nodosum is simply an indication of systemic vasculitis. It does not mean absolutely nothing. So erythema nodosum is completely useless. Regarding your case, the symptoms of which can correspond with sarcoidosis, it can correspond with systemic lupus versus other seronegatives. It can correspond with HIV, TB, other forms of infection, and since the systemic review was not done completely, some points were missed. What is in favor of sarcoidosis? In favor of sarcoidosis is the joint pain, the eye affection, and the hypercalcemia symptoms. What is in favor of the systemic lupus or other seronegatives? The same points except for the hypercalcemia, although hypercalcemia can be found in cases of seronegatives, especially systemic lupus. Is it HIV or TB? Possible. What is the typical presentation of HIV, TB, cancer, or lymphoma? They are together all in the family package. Why did they come all together in the same package? Because all of them have the same presentation, and the same presentation is anything. So automatically they are included in your differential. Agree?
yes.
So from the point of view of the person or the doctor who took that case and provided us with the feedback, he did consider sarcoidosis versus HIV in one feedback. Other feedback did provide us a systemic lupus. It means that there was no solid diagnosis in that case. And this is the usual trend.
I have a
cases for discussion, for differential diagnosis.
I have a question. How SLE can cause hypercalcemia?
Hypercalcemia. What is the reason of hypercalcemia in sarcoidosis or in cancer?
Sarcoidosis, there is vitamin D overproduction, alveolar macrophages.
And in cancer?
In cancer, there is maybe some bone metastasis from parathyroid-related hormone paraneoplastic.
Okay, so all of that means that those are affecting the body in one way or the other, whether through an autoimmune process, versus a paraneoplastic syndrome, which is essentially an autoimmune process, having systemic lupus, which is an autoimmune as well. Why not present with hypercalcemia? It will not be one feature of them, but again, the point here is not the diagnosis of systemic lupus. This is back to the original point. What is the diagnosis? In that case, there was no definite diagnosis. All the differentials are on the table, and the examiner is expecting you to get him 3 or 4 differentials to be your top most common ones. And you will tell him sarcoidosis, but against sarcoidosis 1, 2, 3. With sarcoidosis 1, 2, 3, against it 1, 2, 3. It can be seronegative arthritis or systemic lupus. With it 1, 2, against 1, 2, and so on. And this is the most difficult part or the most difficult form of such a case, because since there is no diagnosis mentioned, since there is no definite diagnosis in your case, it means that every single point in the systemic review will be considered. Whenever you are going to miss one, it will be revealed during the discussion.
Sir, I have a question. Is there rheumatoid arthritis can be diagnosis differential?
Rheumatoid arthritis can be a differential in that case. It is one of the differentials, but not the first, not the second. Why? The features of rheumatoid arthritis are not typically present in this patient. Plus, the pain is not involving only the hands. Plus, the patient is not sure about the exact duration of the stiffness that she's suffering from.
Okay.
So it is one of the possibilities. It is in my differential diagnosis since she has a family history of a similar condition, but it doesn't have to be. Lady with low white blood cell count and positive family history of rheumatoid arthritis. Do you see any similarity? Yes. In 119 and in 120 now, both of them are young ladies, and both of them have non-specific symptoms of joint pain with or without some form of sarcopenia. Whether there is a family history or not, it doesn't make any difference. You get the point?
Yes.
So it's not ever about the diagnosis. So in order to apply that in a sensible approach, I would consider putting analysis of the stem. This is a joint pain. Analysis of any symptom goes into 8 out of 8 points. I have mentioned that before. If this is a pain, I will add 3 more points. Scope, nature, and radiation. So previous, onset, course, duration, exacerbating, relieving factors with examples. And the examples in cases of joint pain or back pain are very important. Why, Dr. Asma?
Because for health.
Nope, not only for the help. Whenever you are analyzing a pain, the exacerbating factors and relieving factors will tell you is this the inflammatory pain or
Mechanical.
pain. Perfect. Association, focus always on the twins if there is any, and the timing. Just a week from sleep, any diurnal variation is better in the morning, worse in the morning, worse in the evening. And we will add 3 more points for nature and radiation. So this will be the first part, which is analysis of the system involved, of the stem. Then this is joint pain. Joint essentially means rheumatology. So whenever we are considering rheumatology, the first thing that you should consider, we have a note in the pitfall paper, or not yet, that's a primary rheumatological illness. The 18 questions are joint pain. I'm just going to enumerate this to be repeated in session 5. Joint pain, joint stiffness, Raynaud's, change in the color of the fingers on exposure to cold, and tightening of the skin. Then comes the face, rash. Rash comes in 2 questions, rash and rashness on exposure. Then having any red eye or gritty eye sensation, mouth sores or private area sores, that's when for that is private area sore, difficulty in swallowing, Let's put it on a simple looking at the patients, and you can remember that as easy as you can. So those 4 points are in the hands, the joint pain, joint stiffness, Raynaud's, and tightening of the skin. Then on the face, this patient will have skin rash, she will have eye symptoms, and she will have problems with her mouth. And number 8 is going to be difficulty in swallowing. Then she will have problems with her breathing, shortness of breath, those are the lungs. Then there's the heart, any chest pain. Then moving on anatomically, we will have the GIT. So the GIT will have 2 questions, tummy pain and blood emotions. The tummy pain for Crohn's disease and the blood emotions for ulcerative colitis. Then I will get to the kidneys, any change in urine, any frothy urine. Then I will turn the patient to the back. I will look at the back. There will be back pain, then neck pain. Then whenever I reach the neck, I have to ask about trauma. أول ما أوصل لقفاه أسأله مين اللي ضربك على قفاك. Then I will ask about lupus in the context of lymphadenopathy and antiphospholipid syndrome. 2 questions for the antiphospholipid syndrome, history of miscarriages versus history of blood clots. And lastly, I will ask about the medication list to rule out drug-induced lupus. So those are in total going to be something like 16, 17, and 18. 18 questions that can represent any rheumatological presentation for whatever case. Very helpful in station 5 and as well in station 2. So number 1 is going to be the stem. Number 2 is going to be the 18 questions. Those are total of 18 questions to deal with any rheumatological illness. Then I'm going for the differential diagnosis. Differential diagnosis, in order to get a diagnosis, I'm not going to be able to get a diagnosis here, but essentially in the context of doing that, you can tell that I will ask about the family history, the medication history, travel history, past history, and a lot of things that are not covered or should be covered before the systemic review. This is the way to get the 4 mark, because I'm not going to ask about the medication history or the family history as part of the systemic review. No, they are sought much earlier as a part of the diagnosis. Then the systemic review to recap whatever I have missed system by system. Then I will get the history in order to offer help, and you have offered me some help. Thank you for doing that. And lastly, I will end up with the concern. What do I have? So if we assume that this is a case of sarcoidosis, how would you tell the patient, what do I have? How do you answer that? What is the definition of sarcoidosis?
Actually, this is a granulomatous disorder.
Okay, so how would you describe that to the patients? Closure of any case comes in 6 points. You always start by the presenting symptom. Then you name your diagnosis. Then you define this diagnosis. Then you form a multidisciplinary team. And this team will ask for some investigations in the form of blood testing and imaging. And you will arrange for another meeting to discuss the results. This is the standard way of closing a case, keeping in mind 3 points. If you are going to admit the patient, you have to tell him if you will start him on a medication or you are going to stop a medication, you have to tell him. If you need to provide him with a painkiller, if applicable, you will tell him about it. So sarcoidosis is not an autoimmune. Sarcoidosis is simply an inflammatory disorder. So how would you describe that to the patients? This is an exaggerated reaction of your body called inflammation, involving the system that's supposed to defend your body against infections, called the immune system. The reason for which is unknown. That has precipitated your symptoms. For that reason, we will form a multidisciplinary team which will be running some investigations in the form of blood testing and imaging, and we will arrange for another meeting.
Can you please repeat sarcoidosis? What is it?
It's an inflammatory disorder. By that I mean exaggerated reaction of the defensive system of your body called the immune system. And for that reason, we will form a multidisciplinary team which will run investigations in the form of blood testing and imaging, and we will arrange for another meeting to discuss the results.
Sir,
Would you
I
like
have
to
a
admit this
question.
patient, Dr. Asma? Yes.
Yes, patient have mentioned me about the hypercalcemia symptoms.
Mhm.
So I think this should be evaluated urgently. I don't
Okay.
know actually.
This will come to the question, when or are you going to admit this patient or not? What would be the criteria to admit this patient?
If there is a major that is hypercalcemia, neurological problem.
Not exactly. So not every patient with hypercalcemia or dehydration should be admitted. Instead, any patient with end organ affection or end organ damage should be admitted. Meaning that any patient with hypercalcemia is not for admission unless there is an end organ damage to the CNS, to the kidneys, to the heart, to whatever body part that has been affected. And the same is applicable for anemia and for the dehydration. That's why the systemic review is of major importance here, because the systemic review, you didn't ask me, for example, about confusion. Confusion in this patient would be a definite indication for admission. Proper analysis of the renal system to know if the kidneys are still functioning or not. And so on. Heart failure for a case of anemia or dehydration. Dehydration, not heart failure, but anemia, heart failure, yes. Dehydration, if this is affecting the CNS or the kidney, and so on. So as a general rule, any end organ damage or affection of a certain organ as a complication of the presenting symptom is an indication for admission. Agree?
Yes.
Agree. So the take-home message, or let's put it this way, we have done the fighting part, and we did go to the pitfall paper, we did put an approach, and we did apply that approach in 1, 2, 3, 4 steps. So overall, it's a good run, it's a good case, you have done very well overall, just few tiny points to consider and never forget, keeping in mind that the diagnosis itself does not guarantee the full mark in the exam. That's why Dr. Haji, during the discussion, did come up with a diagnosis of sarcoidosis very early. That's fine, that's perfect, but this is not enough for the full mark. Anyone can diagnose sarcoidosis, but the trick lies in, are you able to defend your diagnosis or not? Do you agree?
Sir,
Do you agree?
yes,
Yep.
yes. So I have to ask travel history and HIV history in every cases.
Not in every case. Not in every case. Whenever you think that this is a possible differential.
Okay.
For example, you have a patient who is 75 years of age and he is presenting with a renal failure. How likely is that going to be from HIV? Less likely. But if you have someone at the age of 25, like this lady presenting with unexplained weight loss and anemia, you would definitely consider HIV. So it depends on the presentation. Right?
Okay. Right.
Okay. Hold on for a second. Okay. So if anybody has any question here? Hello? Can anybody hear me?
Yes.
Okay, so do we agree on the previous case? Anyone have any question here? Okay, that's good. So that's a wrap up for today. Tomorrow we'll be getting communication in order to fix the recent cases. Thank you everybody, and I'll be seeing you tomorrow inshallah.